Good afternoon, everyone, and thanks for joining me today for this presentation on breast cancer cryoablation, a practical guideline for patients and physicians. I also want to thank Allison, who's assisting with the presentation today. She's my practice coordinator for breast cryoablation patients, and she'll be collecting questions that you submit through the chat function. I'll respond to the questions at the end of the presentation. To give you some background as to why I thought this was an appropriate topic and effort, you should know that I first learned about cryoablation in 2002 while I was training to be a breast surgeon. And I immediately recognized it as a potential treatment options for breast cancer patients in the future. Because of my interest in it and my faith that it would one day emerge as a viable option, I set about the effort to learn how to do it. That include developing a clinic where I treated patients with benign breast tumors, which was the only thing that was acceptable for cryoablation at the time. And I also taught trainees, breast fellows, how to do it as well. And that culminated in this publication that you see here, a minimally invasive breast biopsy clinic. That's the name of the thing that I developed, an innovative way to teach breast fellows how to perform breast ultrasound and ultrasound guided procedures. The real intent was to not only teach them how to do it, but also to begin to develop my learning curve so that when cryoablation did become a reasonable option for patients with breast cancer, I'd be well ahead of the curve in terms of my skill set and knowledge base and how to treat patients with breast cancer. That experience also was expanded with relationships that I developed with other experts in cryoablation around the globe. You see this image here of Dr. Fakuma in Japan, who in 2009 had already spent years treating patients with breast cancer with cryoablation, and also had relationships with Dr. Korpan from Australia and Dr. Xu from China, who have been pioneers in cryoablation of everything else. And through them, I learned a lot about the procedure and also gained insights on how to apply it and to do it much more effectively. And then, as some of you know, I was one of the principal investigators in the ACOSOG Z1072 study, which is the first U.S. study, first multi-center U.S. study that looked at the use of cryoablation in imaginative breast cancer. It was a study in which patients with tumors under 2 centimeters underwent cryoablation, followed by excision of the cryoablation site. And the goal was to determine how effective cryoablation was at killing the tumor. What we learned from the study was that for tumors under 2 centimeters in size, there was a 92% rate of complete kill. And for those under 1 centimeter, it was 100% effective kill rate. Now, one question you might ask is, why were there any situations where the cryoablation was not completely effective for these patients? Well, the answer is based on two things. Number one, we've since learned a lot about the limitations of imaging and how important quality imaging is in selecting the right patients. But there was also an experience component that at that point in time, the surgeon experience was limited. And so some of the failures had less to do with the ability of cryoablation to kill cancer, but more to do with the ability of the surgeon or the radiologist performing the procedure to accurately target and complete the lesion. So it's not just a matter of the technology, it's a matter of the skill set, and that's where a learning curve becomes really important. Now, after that trial, I launched the FROST trial, which is a trial of patients who underwent cryoablation with follow-up, not without surgical excision. We performed needle biopsies of patients 6 months post-cryoablation, but we did not remove the tumors based upon confidence that we developed in the previous study. Now, this study is close to enrollment, but we are in the process of collecting data on patients previously treated so that they can be published within the next year. But it's important to know that this was one of the first steps forward beyond just cryoablating, but also demonstrating that we could leave the tumor in the breast without removing it with surgery, which is, of course, the ultimate goal for cryoablation. And now, as some of you know, I'm also conducting a study looking at the use of cryoablation for DCIS. This is actually one of the first studies of this type in the world. And the goal is to examine the use of cryoablation in the treatment of DCIS as a substitute for surgery or as a substitute for watchful waiting. And I'll discuss this a little bit more in a few minutes. So all of this history is what brings me to prepare this breast cancer cryoablation guideline. I bring 20 years of experience performing cryoablation, including about 15 years of performing cryoablation of breast cancer specifically. And all of that means that I've had 20 years of learning from the past to understand how best to apply it and how to do so more effectively. And so my goal is to bring this information to patients and providers who may be relatively new to cryoablation and who need to learn more. So the question is, why is that important? Well, there are a couple of reasons why that's important. I would say 3 or 4. Number one is that currently there are new providers who are now performing cryoablation, and for them, my goal is to share my 20 years learning curve, because to be frank, if I knew now if I knew then what I know now, I would have done things differently then. You know, just as in other areas of life, we learn over time, and it's probably true for all of us that if we knew then what we knew now in our personal or professional life, we do things differently. So I'm trying to share my years of experience with those who are relatively new to it so that they don't have to go through the same rate of learning curve that I went through. And number two, as a patient advocate, I want to make sure that patients understand the possibilities, but also the limitations of cryoablation and how it fits into the overall breast cancer continuum. And as a cryoablation advocate, I want patients and providers to understand that when cryoablation is misused or mishandled, or when patients are mismanaged, it ultimately will undermine the success and future of cryoablation, the future that I've been working so hard to establish. Lastly, by producing a document as a guideline, it's a tool that providers or patients, more importantly, can take to their providers to inform them about it. Obviously, I've been doing webinars and videos, but it's not like you can send your doctor, 12 months of videos to review prior to or after your appointment. But a simple document that you can hand to them or highlight certain things that may make it easier for you to communicate to them your interest in cryoablation and to also educate them about cryoablation. Lastly, say that there is, I do have a bit of history in guideline preparations. I had the privilege of leading the effort to prepare the performance and practice guidelines for the use of preoperative chemotherapy for breast cancer. This is an effort that was performed on behalf of the American Society of Breast Surgeons. I included the input of other physicians that you see here, but it was a very comprehensive review of the topic, provide kind of rules of engagements for how to approach patients who are being managed with chemotherapy prior to surgery. Some of those messages you hear about in this presentation. But what I'm doing differently with this breast cryoablation guidelines is that I'm extending the opportunity for patients, the ultimate constituent, for patients to participate in the drafting of the guideline. And for that reason, I've made the guideline available on my website, cryoablation.com. If you go to the top where it says about a draft publication, you can see this page where you can download a draft. It's a draft, I emphasize. But my goal is to formalize or complete the draft within the next couple of weeks and to submit it for publication so that it is a document that you'll be able to use. So the draft is available now. It is a draft, and there's a place and some instructions where you can submit comments or questions about the draft that I'll do my best to address in the final document. Now, as most of you know, cryoablation is emerging as a minimally invasive alternative to breast-conserving surgery for the management of breast cancer. Our goal with cryoablation is to essentially do the same thing that we would do with a lumpectomy, which is to treat the tumor, which is shown here in red, by killing it with ablation. We ablate a total volume of about 4 by 3 by 3 centimeters. That's called the zone of necrosis, shown here in gray. And we can achieve that much ablation by freezing an area that's about 5 by 4 by 4 centimeters, which you see here as the ice ball. The goal with this approach is to treat a surgical margin of about 5 to 10 millimeters, which is what we aim to do generally when we perform surgery. And of course, after cryoablation, patients may be candidates for adjuvant therapy, meaning adjuvant chemotherapy or adjuvant endocrine therapy or adjuvant radiotherapy or some combination of the above. But cryoablation, at least in its original conception, was not intended to be a standalone treatment. It's a standalone treatment supported by other therapies. Now, There is some key, I think, advantages of cryoablation over traditional surgery. Number one, cryoablation expands breast cancer treatment options for those seeking to avoid traditional surgery due to philosophical reasons or health concerns or other reasons. Cryoablation can be performed under local anesthetic in the office setting, so it's much more logistically feasible. It minimizes or eliminates the potential side effects of breast cancer surgery, such as seromas and hematomas or infection. Eliminates the need for general anesthesia, such as which can potentially cause nausea and vomiting and or complicate other health conditions. The procedure has minimal impact on patient quality of life and also permits almost immediate return to daily activities. Unlike cryoablation, unlike surgery, cryoablation also does not remove tissue, and therefore it eliminates the need for corrective or cosmetic surgery that is done or may be needed when surgery such as lumpectomy results in disfigurement of the breast. With cryoablation, for the most part, there's no change in the ultimate shape or size of the breast, and so the breast contour and appearance is preserved, and that's what eliminates the need for corrective surgical procedures. Now let's take a look at the evidence. Now, currently, there are no randomized controlled trials that have been completed and published looking at the use of cryoablation compared to lumpectomy. However, we do have some information that will be emerging and some trials that are currently underway or will soon be underway to look at that comparison. Here's one, cryoablation versus lumpectomy. This is a trial that will be sponsored by Hologic. It's a trial that's currently in development, likely to open at the end of 2023 or 2024. It's a non-randomized controlled trial that will compare women treated with lumpectomy to those treated with cryoablation. There'll be about 230 patients with cryoablation, 690 with lumpectomy, a total of 920 patients. The study will be open to women with age 40 and older, tumors 2 centimeters or smaller, node negative, hormone receptor positive, grade 1 or 2. They'll have standard of care axillary management, standard of care systemic therapy, and standard of care use of radiotherapy. Patients will be followed for 5 years, and the goal is to look at the local recurrence rate at the end of the 5-year period. I've been helpful in the design of this trial, and based on current discussions, I may actually be the principal investigator of the trial, but that remains to be finalized. But that trial will soon be emerging and will be one of the most important contributors to make one of the most important contributions, I think, in terms of moving cryoablation forward as an alternative to lumpectomy. There's another trial that is soon to be opened at Washington University in St. Louis. It's a randomized controlled trial of 256 patients, half of whom will receive cryoablation, the other half will receive lumpectomy, and they'll follow patients over years to also look at the local recurrence rate. Now, in the absence of published randomized controlled data, we do have data published recently from the ICE3 trial, was published last year. It was a study of patients that received cryoablation followed by without subsequent excision. There was no comparison group compared to them that looked at how they compared to lumpectomy. So it was a cryoablation alone study. It wasn't a comparative study of cryoablation versus lumpectomy, but still they had some important findings. It was a study of 194 patients. The patients had univocal breast cancer, ultrasound visible breast cancer measuring 1.5 centimeters or smaller. The tumors were ER positive or PR positive and HER2 negative. Patients, the study enrollment was restricted to patients 60 years and older. The mean age of the patients actually enrolled was 75. About 75% of the patients took anti-estrogen therapy, and about 14% had radiation therapy. And with 3 years of median follow-up, it was observed that the local recurrence rate amongst these patients is about 2%, which is a number that we consider quite low. It's important to know that these are relatively favorable tumors. They were small, they were hormone receptor positive, and most patients took anti-estrogen therapy. The patients are also older, but still, this is sort of the lowest hanging fruit, the population of patients for whom cryoablation was originally intended, the ones that are most likely to achieve successful results with a single ablation. And so that's what we see in this important study that is helping to establish and open the door to cryoablation for these early stage breast cancers. I also am listing the Frost study, which I already mentioned, which was when it was previously reported had a recurrence rate of 1.1%, although that number is in the process of being updated. So I'll have to share it with you sometime in the coming year. And we also can look to the experience from Japan at Kamina Medical Center, the study that has been conducted by Dr. Fukuma, whose photograph you saw earlier. He looked at cryoablation and has 6 years follow-up showing a recurrence rate of about 1%. It's important to know that although his patients were on average younger, a mean age of 57, his patients also had tumors that were small, 15 millimeters or smaller. All of the patients had a lymph node biopsy, sentinel biopsy. All of them had whole breast radiotherapy, and all of them had either endocrine therapy or chemotherapy if needed. So even though the numbers are great, local recurrence rate 1% at 6 years, it's important to understand that these patients weren't treated with cryoablation alone. They were treated with cryoablation plus adjuvant therapy. And that's really kind of the ideal situation, or at least it was the original place where, cryoablation is intended to exist, just like lumpectomy. It's intended to coexist with additional therapy, radiotherapy, medication therapy, and potential lymph node biopsy in many situations. I'll talk about some of the exceptions in the upcoming slides, but the point is that cryoablation was intended to be supplemented by other therapies to help to reduce the risk of recurrence. It wasn't intended to be as a standalone therapy. It can be in certain circumstances, but you should understand those circumstances, and I'll explain them as best I can today. Some of those circumstances, at least. Now, although I've described the kind of the best case scenario for the use of cryoablation as a treatment for stage 1 breast cancer, you all know, or some of you at least know, that I have published and have advocated for a more expanded use of cryoablation, sort of in a case-by-case basis for patients who, for one reason or another, are simply refusing to have adjuvant therapy or simply refusing to have surgery. In this publication, which I published during the pandemic, looked at 6 pragmatic indications for cryoablation for stage 0 through stage 4 breast cancer, and also for local recurrent breast cancer. And it basically categorizes the options as either definitive, such as you can use cryoablation as a standalone treatment without intent. I won't say standalone, but using cryoablation as the definitive tumor treatment with no intent for surgical removal subsequently, that would be the definitive treatment, or to use cryoablation as a stopgap or temporary treatment, where you basically use cryoablation to kill the tumor until it's more convenient to treat it with surgery later. So these are some of the ways that cryoablation can be used in a more expanded context for someone who, for one reason or another, is not willing to undergo surgery now or willing to undergo surgery ever. Now, let's look at the pre-treatment assessment, because this is where, this is what's really important in terms of ensuring good long-term outcomes for patients treated with breast cancer, whether they're treated with lumpectomy or whether they're treated with cryoablation. Now, it's important to know that the last 2 decades has seen steady improvement in breast cancer survival rates. As you see from the slide, the 5 to 10 year survival rates are steadily increasing. The incidence is plateauing and slightly declining, and the mortality rate is declining. However, it's important to also know that although these major sources of sort of progress, meaning better outcomes, are largely enabled by early detection and earlier treatment of breast cancer, there are other factors that contribute heavily, like an improved understanding of tumor biology and the targeted use of anti-cancer drugs based upon the tumor biology, the adoption of diagnostic and treatment protocols that prioritize evidence-based practices, and eliminating treatments that don't really work very well or add significant morbidity without much benefit. Now, in the context of those improvements, the potential hazards that patients face, particularly patients who are looking for non-standard treatment options, is that they're often left to navigate themselves through a complicated cancer journey, without the steadfast guidance of an expert surgeon, a surgical oncologist, a medical oncologist, or a team of these individuals who are helping to ensure that they get to where they need to be with effective cancer treatment with the low risk of recurrence and with the side effects that are low as achievable. Now, it is true that even patients seeking standard care may not always have access to the things we're going to describe, but I think the potential hazards that are faced by cryoablation patients are particularly important because they often are sort of navigating around the standard practices in breast oncology. For example, these patients often have inadequate understanding of the disease extent and an inadequate understanding of the risk of recurrence. They often have a poor understanding of the pros and cons of various treatment options. In my opinion, they often experience fragmented care with a lack of appropriate coordinated specialist referral. They experience inadequate use of genetic and genomic testing, and they have inappropriate use of cancer staging in many cases. Now, whether or not a patient experiences those can also depend upon the person that they're engaging with, the provider who actually performs a cryoablation procedure. As you know, many patients seek cryoablation amongst surgeons, some seek cryoablation amongst radiologists. And although both groups of individuals, when appropriately trained, have the skill set to perform the technical aspects of inserting the needle into the tumor and freezing it completely so that it's killed, there are differences, however, in how they manage a patient, not just a tumor. For example, surgeons customarily assume responsibility for either administering or coordinating all aspects of the patient's initial course of cancer care. They determine the proper sequence of cancer care. For example, if the patient should have surgery first versus chemotherapy or anti-estrogen therapy first, surgeons order genomic testing when appropriate. They perform genetic counseling and testing. They order the appropriate staging workup. Surgeons determine the most appropriate management of the lymph nodes and perform the lymph node procedure if indicated. They perform detailed and extensive counseling sessions with the patient about the entire cancer treatment spectrum, not just the cryoablation treatment. They refer and coordinate care with medical oncology, radiation oncology, functional medicine, and others. They prescribe appropriate medications and also order follow-up imaging studies. These are the daily routine practices of surgeons who perform cryoablation, and not necessarily the routine practices of radiologists that perform cryoablation. So in this moment, I am expressing a bias, but I'm expressing the bias primarily because, performing cryoablation is more than just treating a tumor. It's treating the entire patient and making sure the patient is worked up properly and has appropriate follow-up. And so those activities are routine activities for surgeon, not so much for radiologists, unless a radiologist is working with a surgeon or another provider who accepts responsibility for those activities. There is a saying that our lives are defined by opportunities, even ones we miss. And so the point here is that the long-term success of cryoablation depends less on the cryoablation procedure itself, but more on all the steps that are done before and after the cryoablation procedure to optimize good long-term results. So in that context, I'm bringing forth the concept of an accountable provider. This is sort of a proposed concept that I have, which is that the best long-term results are achieved by a cryoablation provider who is accountable for addressing or coordinating the entire spectrum of the patient's initial breast cancer care. Therefore, the most important question that a patient should ask the provider, I think, in the initial consultation or initial communication is whether or not he or she will share responsibility for managing or coordinating the patient's overall course of breast cancer care. If the answer to that question is no, my suggestion is that they should seek care from someone else who will assume that responsibility. Otherwise, the patient will be left to figure it out on her own. So let's talk about the components of the proper pre-treatment assessment and management. It begins with a high-quality digital mammography, which ideally would be 3D or tomosynthesis, as shown here. The idea here is that you want to have high-quality imaging because you want to be able to find things that will impact treatment and potentially impact your risk of local recurrence. For example, with high-quality mammograms, you might be able to detect in situations where there's more than one tumor in the breast, not just the one you're focused on, but perhaps a second one, which obviously would impact both the risk of recurrence as well as the potential approach to cryoablation. We also look for spiculations. This is a tumor, but spiculations are basically extensions or arms that extend out from the tumor that would need to be included in the cryoablation zone, because this is an indication that the cancer is actually extending along these little tracks. And to treat the tumor without accounting for these spiculations will leave the patient with a higher risk of recurrence at these sites. So having high quality mammograms and having a provider who's looking for these additional findings is important for excellent long-term outcomes. We also have the need to look for suspicious macrocalcifications. Macrocalcifications are only reliably seen on mammograms. So if someone doesn't have high quality imaging or refuses mammography, there's a potential that there'll be suspicious macrocalcifications left in the breast, left untreated, that could be the source of recurrence. And just so that you understand why calcification is important, I included this image, which shows you a case of DCS, ductal carcinoma in situ. This is actually an expanded duct containing cancer cells, which are these cells here. But this great big purple thing in the middle is actually a calcium deposit. A calcium deposit forms when the cancer cells die and get petrified by the body, by the collection of calcium. On a mammogram, we can't actually see the DCS. We can't actually see these cancer cells. What we can see is a calcium deposit. So wherever these suspicious calcifications are seen on a mammogram, we want to evaluate it because we suspect that there's possibly cancer surrounding it. And that's why having a mammogram done prior to cryoablation, having a mammogram done with the intent of assessing the extent and location of these macrocalcifications is important to making sure that they're managed appropriately. Either that the patient is excluded from cryoablation because of them, or the person performing cryoablation intentionally includes these areas in the treatment zone. Breast ultrasound is also important. I've included a couple of examples here where ultrasound, ultrasound revealed features of the cancer that were initially overlooked by ultrasound, but that needed to be accounted for to ensure proper treatment. For example, this patient came to me with an impression of a cancer that was shown here, but further scrutiny showed that the cancer was actually extending along this spiculation and also extended in this direction along this spiculation. And so recognizing these extensions was important in administering cryoablation appropriately to this patient. It not only focused on the obvious thing, but also looked at the more subtle findings that were revealed by ultrasound. And this is another example of someone who came with what was thought to be an obvious tumor by ultrasound, this dark area, but a more astute interpreter of ultrasound, I consider myself one of them, would recognize that there's also some edema around the tumor, this white area, that actually is part of the cancerous process, and that also needs to be included in the cryoablation field. So I wouldn't measure this tumor from here to here. I measure this tumor from here to there, because that's the full range of the changes that are seen in association with this malignancy, this cancer, and that would need to be included in the ultrasound, in the cryoablation treatment. Diagnostic axillary ultrasound is also important. We don't rely upon how the underarm feels. We have to use ultrasound to look at subtle changes in lymph nodes that could indicate the presence of spread. Here's a case of a normal looking node. We say that it has appearance of sort of like a Twinkie, where it has a thin outer cortex and it's filled with fat in the case of a lymph node. This is a lymph node that's a little bit distorted. You see there's a thin cortex here, but then the cortex becomes thickened in this area, kind of bulbous. That's an indication that there's possibly cancer growing in that part of the lymph node. This is one that should be biopsied and treated in some manner. We'll talk about that in a little bit. There's also breast MRI. Breast MRI is important because it can reveal features of the cancer that are not apparent on a mammogram or ultrasound, primarily because it's looking at the cancer with a different lens. It uses an IV contrast called gadolinium that flows through the blood vessels of the breast and highlights or enhances those areas where the blood vessels are abnormal, such as those that are developing in association with the cancer. This is an example of someone who had breast MRI, and you see an enhancing tumor here, which corroborated or confirmed the findings that were seen by ultrasound and mammography in this patient's case. However, in the next example that I'm showing you, this is someone who had a tumor that looked to be more discrete, but by MRI, we saw additional findings that impacted how the patient was treated. This is her breast. This is enhancing tumor, but we also saw that there were spiculations seen on MRI and also other foci of the tumor seen in the outer breast that also needed to be included in the cryoablation treatment zone. So we didn't only focus on this, which is a thing that was shown by mammography and ultrasound, but also address this, and this, the things that were only seen by breast MRI. So breast MRI has the ability to show you these speculations, the presence of multifocal, multi-centric cancer, and also has another look at the opposite breast so that you can potentially detect a bilateral cancer, which we generally find in about 5% of women. Cancer in the other breast, about 5% of women. MRI also allows us to sort of manipulate the image. This is not the perfect example of this, but at least it'll make the point that, it helps to see the tumor three-dimensionally, to know, what direction things extend, because tumors aren't necessarily round, they're quite irregular. So using MRI, we can actually rotate the image to see angulations or speculations or other tumor foci that would need to be included in the treatment zone. So breast core biopsy. So establishing the diagnosis requires that we perform a core biopsy or needle biopsy. The benefits of the breast needle biopsy is that it allows us to insert a marker. In addition to obtaining a diagnosis, it allows us to insert a marker, which we call the clip or a chip, at the site of the breast abnormality. This is important because it confirms the site of the biopsy, especially if the tumor becomes less obvious after the biopsy. Sometimes it's bleeding, or maybe the tumor is just very small. And so when it's biopsied, it becomes less detectable. The clip helps us confirm the location. If you're a patient who's treated with pre-cryoablation chemotherapy, where the tumor may shrink as a result of the chemotherapy, having a marker there helps just to confirm the location, because the tumor might actually disappear, or at least the mammographic and ultrasound and imaging evidence of the tumor might actually disappear at the end of the chemotherapy treatment. And getting back to that site, knowing that site, having it marked with a clip is important to getting back to the right spot. Now, I recognize that not all patients are willing to have a diagnostic needle biopsy due to concerns potentially penetrating the tumor. People express concerns about potential tumor spread, but you should know that there's really no evidence of needle biopsy-related metastasis actually happening. So tumor cells may displace, but that doesn't mean they displace and set up home and grow in another location. On the other hand, for those that are reluctant to have a needle biopsy because they're avoiding that experience, the needle penetration of the tumor, there is a risk in waiting. And this study actually looked at the time interval between detection of an abnormal finding, like an abnormal mammogram, and having the biopsy performed, and determined that past 3 months, a 3-month delay from abnormal imaging to a biopsy, which revealed cancer, was associated with a 20% reduction in overall survival. So waiting actually did or does directly impact survival, whereas there's no proof that performing a needle biopsy itself directly impacts survival. So I encourage patients to move forward with a diagnostic biopsy so that they can get to a diagnosis and get to treatment. We have also important to know that in terms of how we approach tumors, sometimes the tumors that we see are quite small, or after the biopsy, they are just not well seen. And because they're not well seen by ultrasound, it'd be difficult to treat them or perform ultrasound-guided cryoablation. Now, fortunately, there are devices that are available, markers that are available that can make an ultrasound invisible tumor become visible, or at least the site of the tumor become visible. This slide here shows various kinds of markers that are available in the market. But one of them, the one that I like the most, is this marker that looks a little bit like a straw. It's an ultrasound visible marker. It has a component that is made out of collagen and is absorbed eventually, but at least in the first few months after its placement, it stands out on ultrasound, allows us to target an area by ultrasound that might not otherwise be targetable by ultrasound. It makes the tumor site visible because we can see this ultrasound visible marker. We're actually looking at the use of these kinds of markers in this DCS cryoablation study. The purpose of this study is to utilize cryoablation in the treatment of DCS with the goal of preventing it from developing invasive cancer. The problem is that DCS is not usually visible by ultrasound. So in order to make DCS visible by ultrasound, we insert a marker at the site of DCS to treat the area. This is a study of women with DCS measuring 2 centimeters or smaller by imaging. The patients undergo marker placement so that we can see the site. They undergo cryoablation. After cryoablation, they undergo a needle biopsy of the cryoablation site to confirm that the area is dead. We do that biopsy 6 months after cryoablation, and then they go on to annual follow-up. This is an ongoing clinical trial. It's open to enrollment. So if you know someone who qualifies, please refer them to us. It's sponsored by a number of individuals, including the Ice Girl Company, Helen Ray Breast Cancer Foundation, as well as Corey Research Foundation. And through their sponsorship, the treatment is available at no cost to patients. So we're providing the cryoablation procedure at no cost, and my practice donates the staffing time for the procedure. It's important to know that lymph node needle biopsy is also important. This image shows a biopsy performed of lymph node. The image here shows the actual lymph node with the needle entering the lymph node. In this, just like the breast, we leave a marker at the time of the biopsy so that there's a clip to identify that node if it ever needs to be removed. The presence of the clip helps to document the correct node that's been biopsied so that it can be addressed down the road if need be. Now, unlike the past, when we usually perform what we call biomarker testing on the specimen after surgery, the current practice, however, is to perform what we call biomarker testing or receptor testing on the core biopsy sample itself. As most of you know, all breast cancers are sort of categorized by their receptor expression. You have estrogen receptor positive tumors or negative. You have progesterone receptor positive or negative tumors. And that makes up about, estrogen receptor positive and progesterone receptor positive tumors make up about 75% of breast cancers we see today. About 20% of breast cancers are also HER2 new positive. They could be positive or negative, but about 20% are HER2 new positive. And we also have this third category of tumors, which we call triple negative, about 50%, that lack the expression of these 3 receptors. So they're estrogen receptor negative, progesterone receptor negative, and HER2 new negative. We call them triple negative. There are other biomarkers we look at, but those are the key ones. But it's important to know and to have these tested on your core biopsy sample and to discuss the significance of them with your breast cancer provider, your breast care provider, your cryoablation provider, because they impact potentially on how you're treated. For example, for patients with HER2 new negative, but hormone receptor positive, that's either ER positive or progesterone receptor positive breast cancers, those patients are usually treated with surgery first, or in the case of cryoablation, are treated with cryoablation first without any, with an expectation that they'll have an excellent outcome based upon that treatment sequencing. However, for patients with HER2 negative and hormone receptor negative breast cancers, what we call triple negative breast cancers, evidence shows that those patients have the best outcome when they're referred to medical oncology and treated with chemotherapy first, especially if the tumor is over 1 centimeter or if they're node positive. So for these patients with triple negative breast cancers, they're best referred for neoadjuvant, what we call neoadjuvant chemotherapy, so they can receive chemotherapy for the triple negative breast cancer first, and then return for cryoablation if they seek cryoablation. The same principle is true for patients with HER2 new positive breast cancer. Regardless of the estrogen receptor or progesterone receptor expression, patients with HER2 new positive breast cancers are referred for anti-HER2 and chemotherapy, anti-HER2 therapy and chemotherapy first if the tumor is 2 centimeters or larger or node positive. And again, the studies show that survival outcomes are improved when the treatment is sequenced with systemic therapy first, followed by cryoablation or surgery for patients that are seeking cryoablation or surgery. It is certainly within the right of a patient to say, I'm not going to have systemic therapy. I only want to have cryoablation. Or I only want to have cryoablation now. I'll think about systemic therapy later. but it's important to know or communicate that by making that decision, they're potentially impacting their survival, and that should be clearly communicated to them. So if they are triple negative or they are HER2 positive and their tumor is, as I've indicated, a centimeter or more or no positive for triple negative, or 2 centimeters or more or no positive for HER2 positive, that those patients have a survival improvement by sequencing the therapy with drug therapy first, followed by either surgery or cryoablation. Now, for patients in the first category, those that have HER2 negative but hormone receptor positive breast cancer, we do have additional tools that can be used by the patient to assess the need for chemotherapy. We call that genomic testing for invasive cancer, specifically for ER positive or PR positive and HER2 negative breast cancers. There are tools that are commercially available, tests that are commercially available that can be done to gauge whether or not that patient benefits from chemotherapy. We assume that anyone with an ER positive or PR positive breast cancer will accept anti-estrogen therapy as one of the treatment options. But the question with these tests is, do they also benefit from adding chemotherapy to the anti-estrogen therapy? And so there are several tests. This slide is from the NCCN guidelines showing the commercially available tests for looking at the benefit of chemotherapy. These tests are appropriate for people, again, with hormone receptor positive breast cancer, HER2 negative breast cancer. So it's not appropriate for someone with a HER2 positive or triple negative breast cancer. For these cancers, those tests always show a high risk of recurrence because, in fact, they do have a higher risk of recurrence. But for genomic testing, the main aim for using it, as I mentioned, is to assess whether or not the patient will benefit from chemotherapy in addition to, or rather on top of, the anti-estrogen therapy that we would expect them to receive. But genomic testing also helps helps a patient assess the use of anti-estrogen therapy, especially if she's reluctant to taking it. What I mean is that sometimes people say, I'm not going to take anything. I'm not going to take anti-estrogen therapy. I'm not going to take chemotherapy. But if genomic testing shows that they have a high risk of recurrence, that might motivate them to at least consider anti-estrogen therapy, even though they would also benefit from chemotherapy. They would at least maybe reconsider taking anti-estrogen therapy once there's documented proof that they have a high risk of recurrence within 10 years. Genomic testing can also affect the similar decisions about radiotherapy and sentinel biopsy, and also, fortunately, help to reassure those wishing to avoid chemotherapy. I'm going to restate that. There are situations where people are uncertain about whether or not chemotherapy is needed, but if you have a genomic test that shows that the risk is low for having distant recurrence, then it reassures you and your provider that there's no need for taking chemotherapy. We'll move on to staging for distant metastasis. This one is pretty simple. The guidelines show that there's no need for staging for stage 0, 1, or 2 breast cancer. So although sometimes people want to have scans like CAT scans and PET scans and bone scans, those studies are inappropriate for patients with stage 0, 1, and 2 breast cancer. The risk of having distant metastasis is so low, or detecting it is so low, that those tests tend to be useless. However, for patients with higher stage disease, stage 2, we recommend including labs for their staging, stage 3, scans and labs, and stage 4, scans and labs. Beyond that, screening should be symptom-based. So if they're complaining of bone pain, there should be appropriate imaging for the bone. If they're complaining of abdominal pain, there should be appropriate imaging for the abdomen. If they're complaining of headaches, there should be appropriate imaging of the head. In that case, it's symptom-based. But for a patient presenting with no symptoms of distant disease, the NCCN guidelines recommends this screening regimen for those patients, the staging regimen for those patients. It's important to think about genetic testing. As you know, most breast cancers are sporadic, meaning that they just happen by chance, but about 5 to 10% of breast cancers are hereditary. It's important to recognize those breast cancers. You can only do so by testing. And fortunately, there are guidelines produced by the NCCN guidelines. They're updated quarterly that identify patients for whom testing would be appropriate because of their statistically elevated risk of having a breast cancer mutation, such as patients with diagnosed with breast cancer at age 50 or younger, or those with first-degree relatives with a diagnosis of breast cancer at age 50 or younger, family history of ovarian cancer, family history of metastatic prostate cancer, family history of pancreatic cancer, or multiple generations in which there are breast cancer diagnoses. Also, triple negative breast cancer is one of those that the guideline recommends, for which the guideline recommends genetic testing. Just want to put in a plug about the importance of timely care. There's a lot of data that have emerged that patients who delay their care, or patients whose care is delayed by the system, have worse outcomes. The evidence shows that beginning 2 months after a needle biopsy is performed, that it is at 2 months after the diagnosis is made, as assessed or judged by the date of the needle biopsy, past 2 months, each additional month delay in care is associated with a 10 to 15% relative reduction in overall survival for patients with stage 1 and 2 breast cancer. So even for patients with early stage breast cancer, if their care is delayed past 2 months, they begin to suffer an increased risk of death because of the delay. And that increased risk increases for every additional 30-day delay that they experience. So timely care is important, and that principle has been shown by any number of papers over the last 10 years. These are 2 other examples of it. We're going to move on to just talking about the cryoablation procedure itself. This image here shows you kind of a lumpectomy performed after the tumor was treated with cryoablation. The red area is the area that was treated with cryoablation. This is what we would call the zone of necrosis, which is shown in this graph here as an area that generally spans about 4 by 3 by 3 centimeters. It's surrounded by a zone of injury shown in green, which is an area that's injured but not killed. And then there's a cryohalo, or the red area, 5 by 4 by 4 centimeters, which is the area that's frozen but isn't killed. So what we aim to do, of course, is to kill the tumor here. But in order to kill the tumor here, we have to freeze an area that is that large, and I showed you that in one of the previous imaging. But what we're aiming to accomplish with each ablation is to get an area killed that's about 4 by 3 by 3 centimeters, and to choose a tumor that fits well within that area, or to use multiple ablations if a tumor does not fit well within an area. In this example of a patient with stage 2 breast cancer, 1 ablation zone wasn't sufficient to cover it with adequate margins, so we need to use 2 or more ablation zones overlapping in order to ensure that the tumor is treated with adequate margin. For larger tumors, even more ablations may be needed, and not only might they be needed in one plane, but it might be necessary to sandwich the plane so that you have, say, 3 ablations in the deep layer, 3 ablations in the superficial layer, so that a larger tumor is adequately covered in all dimensions. Here's someone who had a large tumor that required 8 ablations performed in 2 layers. The tumor's extent is shown here. This just sort of represents how the cryoablation was performed, how we oriented the cryoablation zones. But this patient actually had not just these 4, but 4 other ablations that were performed in a different plane in order to get around this area of disease. Here's another patient with a multifocal tumor. She had a large tumor here, which you see on the MRI as that area there, and several other smaller tumor sites in the upper outer quadrant of the left breast. She required multiple ablations to cover the area. For someone performing the cryoablation procedure, it's important to think about whether or not additional biopsies should be performed at the cryoablation site at the time of cryoablation. For example, if the patient is a candidate for genomic testing, but tissue hasn't been collected for that, or if you're not sure that there's adequate needle biopsy tissue for genomic testing, then additional tissue should be obtained of the cryoablation site at that time so that genomic testing can be performed, and so that the patient can have an accurate assessment of whether or not they benefit from chemotherapy. This is particularly important for patients with hormone receptor positive breast cancers. If a patient has had second reason for performing pre-cryoablation core biopsies is a patient who received pre-cryoablation chemotherapy. Often the tumor shrinks, and sometimes it completely disappears. Performing a biopsy at that site helps to confirm whether or not there's any residual cancer surviving the treatments, because even though we intend to treat it, knowing whether or not there's surviving residual cancer cells at the site helps to guide subsequent treatment that the patient may be offered. And I'll talk about that briefly in a moment. Lastly, for a patient with, say, a large area of disease like DCIS, that diagnosis is often made based upon biopsy of one area of the DCIS. But if the area of DCIS is large enough, like maybe 3 to 4 centimeters or larger, it makes sense to biopsy other areas because, in fact, biopsy in another site might reveal an early site of invasive cancer that was not accounted for in the initial biopsy that showed only DCIS. So more complete sampling of a large area DCIS is recommended to rule out hidden invasive cancer. Generally, what we're speaking about in cryoablation is targeting a single lesion, but sometimes the area of disease is larger than can be treated with a single ablation. And it's also the case that sometimes the area that you need to treat is not ultrasound visible. Maybe a portion of it is ultrasound visible, but there might be portions that are not ultrasound visible. And that was the case in this image, a patient where the patient had an ultrasound visible tumor that's shown here, but she also had calcifications that extended beyond the tumor that were not detectable by ultrasound. To help ablate this tumor, it would benefit the patient to have an ultrasound visible marker placed in this area so that the borders of this disease process could be seen and included in the cryoablation zone. And that means sometimes when we have these sort of situations where we have parts that are not visible by ultrasound, sometimes we can get by with one clip, but other time we need to place 2 clips. This is her original biopsy site showing DCIS, but the calcification is extended in this direction and in that direction. So she had a placement of a clip here and a clip there to bracket the area. These clips were ultrasound visible. So with the ultrasound visible clips, we were able to treat the entire area more reliably. It's important to know that although we rely upon clips to locate tumors, sometimes clips don't always stay where you intended them to stay. There is this problem of clip migration or marker migration, where although the intent was to place this clip at the site of the cancer, sometimes the clip gets displaced along the needle track as the needle is being withdrawn or as the breast is being released for compression. And the clip might end up actually 1 or 2 centimeters away from the cancer. If your goal was to target the clip and it's in the wrong place, you'll obviously miss the cancer. So someone who's offering this patient cryoablation needs to have a plan for dealing with this calcification, which might require placement of a wire or another clip. But the idea is you have to anticipate and look for clip migration, which happens in upwards of 20 to 30% of patients. So the radiologist, the person performing cryoablation, needs to account for this and make appropriate adjustments. We talk about lymph nodes. Lymph nodes are important because they help to guide a treatment. In evaluating the lymph nodes, we want to know if there are any lymph nodes positive, and if so, the extent of those nodes. Knowing the status of the lymph node helps to understand the need for or extent of surgery, the need for drug therapy, and the need or extent of radiotherapy. In general, lymph node management should mirror surgery. So if you're thinking about cryoablating a tumor, you also have to have a plan for addressing the lymph node. You just can't or should not simply disregard it because sometimes you may have disease that will be your next site of recurrence that could be managed appropriately if the lymph nodes were properly managed at the beginning. Now, there are situations where the risk of recurrence or risk of lymph node spread is so low that lymph node surgery isn't really needed. And there's actually a national policy from the Choosing Wisely campaign by the Society of Surgical Oncology, which recommends that we not routinely perform lymph node biopsy on women with stage 1 breast cancer that are age 70 and older, with estrogen receptor positive tumors or progesterone receptor positive tumors, HER2 negative tumors, for when the patient is willing to take anti-estrogen therapy. The anti-estrogen therapy, when combined with the breast surgery, is sufficient to manage the disease such that removal of the lymph node is not needed. In addition, the risk of lymph node spread is so low that lymph node surgery is not needed. However, for other patients, lymph node surgery should be considered. For women under age 70, it's currently the standard of care. However, a more nuanced approach could also be applied for these patients. In my practice, I use genomic testing to guide lymph node management. If the patient has a low-risk tumor by genomic testing, then I offer her no lymph node surgery, simply monitoring the lymph node with ultrasound. However, if they have a high-risk tumor, such as a genomically high-risk tumor or triple negative or HER2 positive tumor, I recommend a sentinel biopsy for those patients, even if their lymph nodes look negative, because there's such a high risk of lymph node spread in these patients. This image shows a sentinel biopsy procedure. It is a procedure that we perform to determine if there's lymph node metastasis in a patient whose lymph nodes look normal by ultrasound and by exam. It involves injection of tracers in the breast that are taken up in the lymphatic drainage of the breast and is filtered out by lymph nodes. The lymph nodes that filter out, the first ones that filter out the dye, which is shown here, or the radioactive, which is shown here as blue, or the radioactive substance, which is shown here as yellow. We call those sentinel nodes. And this is the actual appearance of a sentinel node, a blue sentinel node, with the lymphatic from the breast coming to the lymph node. The lymph node, again, we routinely perform sentinel biopsy in younger patients or patients with higher risk disease to see if there's any lymph node spread. But there are some important considerations for how the lymph node biopsy is performed, especially if you're also planning to perform cryoablation for that patient. Specifically, for patients with tumors in the upper outer quadrant of the breast, the tumors in that location or ablation of tumors in that location can interfere with the ability to map the lymph nodes. And so you have to think about that in terms of the planning and how the lymph node biopsy is performed. This image here shows a fluorescent dye that was injected into the nipple area, which is where we normally inject the tracers for cryoablation procedure. And it shows the flow of the tracer along anatomic structures towards the lymph nodes, through the lymphatic vessels towards the lymph nodes. It's a specific pathway of drainage. I actually trace the pathway on the patient's skin, and you can see these lines here. That shows, drawn on the skin, the location of these fluorescing vessels through which the lymphatic tracer solution is flowing. The point of this is that if I were to perform cryoablation in this area, and the cryoablation were close to the skin, which is where these vessels are, then the cryoablation itself would disrupt the lymphatic drainage and interfere with the ability to perform the sentinel biopsy procedure. The sentinel could possibly not be detectable because the pathway carrying the tracer from the nipple to the lymph node could be disrupted. So if you have a patient with an upper quadrant tumor, which is where most of them are located, and if it's close to the skin, my recommendation is that the sentinel biopsy is performed before cryoablation, or at very least the injection is performed prior to cryoablation so that the fluid can travel from the nipple to the lymph node before the cryoablation is performed. Another strategy to improve the odds of success is also to inject some of the tracer solution, the blue dye or radioactive, around the tumor so that it's a little bit closer to getting to the lymph node. So what do you do with someone with positive lymph nodes who comes in with obvious disease? Previously, I've talked about people with normal looking lymph nodes who are recommending sentinel biopsy, but patients may either have positive lymph nodes that are obvious on their mammograms or ultrasound. This is an example of the mammogram, or they may have a normal appearing lymph node that is then studied microscopically and found to have metastatic carcinoma. So now we have a positive sentinel node. What do you do with these patients? Well, historically, for patients with positive lymph nodes, we recommended lymph node dissection, where we remove nearly all the lymph nodes in the underarm area. As you know, the risk of that procedure is lymphedema, which is something that is often a lifelong complication. And for that reason, we are changing how we perform lymph node surgery now. But at least historically, this was the approach that we took to patients with positive lymph nodes. Now, however, I think there's a lot of evidence supporting limiting the extent of axillary surgery using this approach that I'm going to describe. This is not widely accepted, but it's emerging. We see that this is a trend that is emerging and likely will be more widely adopted. And that involves not removing all of the lymph nodes, but removing the ones that look abnormal, the ones that are grossly abnormal or that are found to be abnormal during surgery, removing those nodes alone, but leaving the other nodes intact. But instead of removing those nodes, adding radiation to those nodes so that the radiation can be used to control disease that might be within the node. So in general, when we perform breast radiation, we irradiate the whole breast. I'm going to talk about breast radiation in a moment. But in the case of a patient with positive axillary nodes, we can extend their field of radiation to cover the lymph nodes that would otherwise be affected, the downstream lymph nodes that are also likely to be effective. This approach is reasonable because we know that radiation of the nodes has a much lower risk of lymphedema compared to surgery. So radiating those nodes as opposed to removing them surgically is safer from the perspective of lymphedema. We know that 20 to 40% of patients who have lymph node disease in one or two nodes have disease in other nodes. So simply leaving those nodes unaddressed leaves a patient at an elevated risk of having recurrences happen. We know that radiation is very effective at preventing growth of microscopic cancer in lymph nodes. So that's one reason to use radiation in that situation. And lastly, as I've already made the point, if we leave those downstream nodes untreated, likely within 1 or 2 years, cancer in those nodes will emerge and the patient will present with a recurrence of disease that could have been managed previously. Now, there's still a risk of lymphedema even when we do more limited surgery, although the risk is lower. And there's some ways that we can further reduce that risk. One technique that I use and some other surgeons use is axillary reverse mapping, where you can inject dye into the arm that's blue that allows us to visualize the lymphatics, the nodes that drain the arm. And by making them visible, we can actually avoid them during surgery, as opposed to accidentally cut them or remove them, which is what happens when they're not clearly visible. Normally they blend in, you can't see them, but by making them blue, they become identifiable and avoidable. On the other hand, we use radioactive tracer in the breast so that we can define the breast node using a radioactive tracer and avoid the arm node by using the blue dye injected into the arm. That procedure is called axillary reverse mapping. And there's also a more sophisticated way of managing lymph node risk. Again, I have experience with this, but this is a technique called lympha that is available to patients who have to have their lymph nodes removed because even though they're blue, they might be abnormal. In that situation, we can connect the lymphatics coming from the arm to the vein, which is shown here, to kind of maintain lymphatic flow to prevent lymphedema from occurring in these patients. Now, of course, many people have come to me with an interest in having cryoablation of their nodes, and although that's a viable approach or feasible approach, is not necessarily always a preferred approach. This example of a lymph node here, and this is the lymph node in the circle with a cryo probe going through it. Although cryoablation lymph node is certainly possible, I think it's safe or safest when the lymph nodes involved are few in number, like 1 to 3 nodes, and when the lymph nodes are near the lower part of the underarm area, not high up where the blood vessels are, because the closer to the blood vessels, the harder it is to freeze that area cold enough to ablate it. The large breast vessels, the large vessels going to the arm, that's what I'm referring to. There's also the potential to perform collateral damage due to the oval shape of the cryoablation zone. Remember, the cryoablation zone is oval. If the lymph node is here, but there's another lymph node here and here, we can't really exclude that lymph node from the ablation. So in some ways, we actually treat more or ablate more tissue with cryoablation than we could injure with surgery. We also can't use axillary reverse mapping when we do lymph node cryoablation. So my preference for a patient who's willing to have it done is to excise these abnormal nodes and then add a radiation. But if they're unwilling to have surgery, or for some reason it's not safe for them to have surgery due to other health conditions, then we can do cryoablation of the nodes instead. Now, in the remaining time, I want to talk with, I'm going to have about 27 minutes left, so I need about 10 minutes to go through the last couple of topics, and then we'll switch to Q&A. So endocancer medicine, this is really important. So unlike surgery and cryoablation, which aim to reduce the risk of recurrence of the tumor within the breast, we need anti-cancer medications to reduce the risk of recurrence of tumor in the places where breast cancer tends to spread, which is to the liver, the lungs, the bone, and the brain. We use medication to prevent cancer cells from growing in those areas, meaning that in the time that the breast time that the tumor has grown in the breast, there have been opportunities for those tumor cells to go to distant parts of the body. And if those areas aren't treated effectively, in time, they will appear. And this is the pattern that we tend to see. The pattern depends on the cancer type, but as you see, for HER2-positive breast cancers, which are purple, and triple-negative breast cancers, those breast cancers tend to recur in the first 2 years after diagnosis if they're not adequately treated. So here you see the purple line for HER2-positive breast cancers, the red curve for triple-negative breast cancers. There's also luminal B, which is a certain type of hormone receptor-positive breast cancer. These cancers have a high risk of recurrence, and those recurrences tend to happen in the first few years if they're not adequately treated. Some have a later peak, but most of the recurrences that we see in breast cancer happen within the first few years, with a diminishing rate happening in subsequent years in most cases. So dealing with the cancer effectively is important, not only because it addresses the potential for distant disease that's in other places, but that disease is likely to show its ugly head or ugly face within 1 or 2 years. It's not something that they can put off 5 or 10 years down the road. Likely they're going to recur early. So it's important to be thoughtful about how you manage them. We talked about various strategies before. I'm just going to list the categories. There's anti-estrogen therapy for hormone receptor-positive breast cancers. There's chemotherapy for high-risk breast cancers. There's anti-HER2 therapy for HER2 positive breast cancers. And there's immunotherapy currently for PD-1 positive breast cancers. I won't get into the details of each of these, but I'll make the point that for a given patient, they would be advised to have one or more of these based upon their tumor characteristics. And of course, as I mentioned before, we use genomic testing to help determine who may need chemotherapy, because genomic testing says for hormone receptor positive patients, even if they're taking anti-estrogen therapy, if they're high risk, they would still benefit from chemotherapy, and we would recommend it. I reviewed the sequence of testing, sequence of treatment previously. I'll just emphasize the point again, that if it's triple negative or HER2 positive, then in addition to getting chemotherapy in most cases, or anti-HER2 therapy in most cases, it's best to give those treatments up front before cryoablation or before surgery, because outcomes, survival rates are better in that setting. I'm going to focus for the moment on HER2 positive breast cancer because it's really important, and triple negative. The reason for pretreatment is that we can improve survival. I mentioned it already. Pretreatment shrinks the tumor and makes and clears the cancer from the breast and distant sites. It also reduces the extent of surgery to some degree, and it helps identify people for whom the cancer isn't completely eradicated. Like in some cases, when we treat with these medications, the tumor disappears completely. In other cases, it doesn't. And it's important to identify the patients for whom it doesn't completely disappear, because those patients may need additional therapy. And pre-treatment and allowing us to see how it responds helps identify those patients who might need additional therapy. I want to focus specifically on anti-HER2 medications. This is from a study with called the Trifina study, in which patients with either hormone receptor positive or hormone receptor negative HER2 positive breast cancer were treated with chemotherapy first, followed by surgery. And what it found, and it's quite impressively, is that for patients with either of those diagnoses, at the time of surgery, at least 40% of those patients and as high as 80% of patients had no remaining disease left in the breast. It speaks to how effective modern anti-HER therapies are, that when they went to surgery, up to 80% of patients had no remaining surviving cancer in the breast and lymph nodes. It was cleared by the chemotherapy. You see there are various kind of drug combinations combined with either Herceptin or Perjeta plus chemo, which achieve these. The results are better for those that were HER2 positive with, but ER and PR negative, lower for those that were hormone positive, but still the numbers were better than we've ever seen. There was another study that made another point that's really important to understand. This is called the Neosphere study. Again, patients had hormone receptor positive, the patients had HER2 positive breast cancers. But this study gave chemotherapy first, some of the chemotherapy first, combined with either Perjeta or Herceptin. And it showed that even though the results were great when you combined it with all therapies, like this is Perjeta plus Herceptin plus chemotherapy, 54% of the patients had no cancer at the time of surgery, no remaining cancer in the breast or lymph nodes at the time of surgery. The results do depend on how treatment is combined. I make this point because I see a lot of patients with HER2 positive breast cancers who I can convince to take Herceptin, but they're not willing to have chemotherapy. Well, I propose Herceptin alone as opposed to doing nothing, because there is some benefit of taking the antibodies. But as you see from this portion of the slide, this population of people had Perjeta and Herceptin combined, and only 2% of those patients had no residual disease at the end of treatment, composed as compared to, and this is the second example of progenitor Herceptin. This is for the hormone receptor positive tumors. This is for the hormone receptor negative tumors. So basically for these patients who are taking only the immunotherapy progenitor Herceptin, they have basically between 2 and 20% of situations where there's no remaining disease. That's much less than what they get if you add chemotherapy. So even though there's some efficacy with taking the immunotherapy alone, I mean, it's better than nothing, it's not nearly as good as the efficacy that you get when you add chemotherapy to it. So the best approach is to take anti-HER2 therapy with chemotherapy. But if you're not willing to do that, at least consider anti-HER2 therapy with antibodies, because it's better than taking nothing. But it's not a lot better than taking nothing. The antibodies combined with chemotherapy is clearly the better way to go. And so that's what patients should consider. Last thoughts. The point I'm going to go through more quickly these last few slides. There's a placement of biomarkers, as I mentioned, when we treat with preoperative chemotherapy. Sometimes the goal is for the tumor to shrink. This is a case of someone who had a large tumor that had pretreatment. This is a tumor after treatment. You can barely see it. All you see is a marker. So having a marker there was important because it helped us identify the tumor site. Otherwise, it would have been invisible. Another example of the same patient with a tumor in the breast, abnormal lymph nodes after chemotherapy. Both of those areas look normal. Having markers in those locations was important to knowing what to treat, either with surgery or with cryoablation. I mentioned that ultrasound visible markers are available to help identify sites that might not be visible by ultrasound. It's also important to know that those markers get absorbed. There's a middle part that lasts, but the part that you see by ultrasound over a 3 to 4 month period becomes less and less detectable. So sometimes it's best to place the regular marker up front, but then prior to the time of the cryoablation, it might be helpful to place a second marker next to the original marker so that you have a fresh ultrasound visible marker prior to cryoablation. If a patient's had chemotherapy and the tumor has disappeared, it's still important to perform a biopsy of the site because you might find that there are some little deposits of tumor that are visible microscopically that you can't see on mammogram, ultrasound, MRI, so that biopsy is important. And although I talked about the importance of having a clip so that you can know the tumor site, it also sometimes is helpful to have a clip to mark the borders, because even though the tumor appears to be gone from these areas, there might actually be, once again, small deposits of tumor in the tumor bed that could be the source of recurrence if those areas aren't completely treated. So I advocate treating the original tumor site so that you can account for the possibility of there being small deposits. I will conclude the presentation on the last topic in the interest of time, because this is really important to discuss. It's the escopal effect. I'll just list these points. There are numerous well-controlled animal experiments that demonstrate the ability of cryoablation of the original tumor to prevent or to prevent growth or to induce tumor regression from distant tumors. Like if you treat the breast, then it might prevent you from having a tumor grow in another part of the body, or it might encourage the regression of a tumor cell or tumor in another part of the body. That regression is called the escopal effect, or that prevention of growth is called the escopal effect, the distant effect. Now, I see many patients who have heard about this and who come to me because they feel or believe that the escopal effect is what they're trying to achieve with cryoablation, and that it might eliminate the need for chemotherapy or other therapies. I want to be very clear that there are no published reports of the escopal effect occurring in humans following breast cancer treatment. Let me restate that. There's no published reports of cryoablation induced a escopal effect in human breast cancer. If you look at the literature, review the literature shows between 1969 and 2014, 46 documented cases of an abscopal effect where treatment of the primary site caused regression of a distant site. But nearly all of those were in melanoma, gallbladder cancer, and kidney cancer. I have yet to find one case where it was clearly linked to cryoablation for breast cancer. It appears as though the best predictors of the abscopal effect in humans is the presence of certain immune cells, like natural immune cells called T cells, and specifically PD-1 cells that express PD-1 checkpoint inhibitors, which do appear to be more common in those cancers where abscopal effect is more commonly seen. They may be seen in triple-negative breast cancer, but still, even in triple-negative breast cancer and HER2-positive breast cancer, the abscopal effect has yet to be reported and published in the literature. We have had many examples where abscopal effect has been demonstrated in animal studies, where ablation of a tumor in the breast caused regression of lesions in the lung, for example. But that has not been shown to happen from cryoablation in humans treated for breast cancer. I have not been able to locate that. We want it to happen. Obviously, we believe in it, but there's no proof of it as of yet. So in my opinion, I think the prospect of an abscopal effect has been somewhat of a disservice to women because it motivates people to make treatment decisions that I think are unhelpful. For example, belief in the abscopal effect encourages some people to potentially refuse anti-cancer medications for the belief that the abscopal effect will control the risk of recurrence, or refuse radiotherapy because they feel that the abscopal effect will reduce the risk recurrence. It's a concept that remains unproven. In fact, the irony is that the only situations of breast cancer where there's clearly been shown an abscopal effect is as a result of radiation-treated breast cancer, not cryoablation-treated breast cancer. And so we have people refusing radiation because they feel that radiation is harmful, yet they're choosing to have, yet they're potentially missing out on the potential benefits of radiation because it is, of the things that are available, it is the only one that has been shown to clearly be associated with an abscopal effect in human breast cancer. So, cautionary note, don't get overexcited about abscopal effect. It is a concept that is not sufficiently proven for cryoablation. It should not be the reason to decline additional therapy, and it should not be the only reason for choosing cryoablation. I am an advocate for cryoablation, but I don't want you to pursue something with the wrong expectations and the wrong intentions. These are the data. So in the interest of time, I'm going to pause now and respond to questions. There actually are a few more slides in the presentation, but all of the points that I'm making in the presentation are available in the draft. You're welcome to review those, the draft. And if you have questions, I welcome any questions you may have. You can submit them through the email that I've included on the website link. Now, I will conclude the presentation by making the following point. I've talked about abscopal effect. I've talked about immunotherapy. I know that there are some people who are utilizing types of immunotherapy at the time of cryoablation. There's no evidence to support that that's safe or effective. There is actually one clinical trial that's looking at it. It's a trial of people with triple-negative breast cancer, which is the only group for which it seems a reasonable approach. But again, it's being done in the context of a clinical trial. I would discourage anyone who's seeking cryoablation to accept injection of immunotherapy unless they're receiving that in the context of a clinical trial, because there are risks receiving it, and there's clearly no demonstrated benefit from receiving it, not in humans. So that's a cautionary note. So I'm going to try to link with Allison now, who has been summarizing some of the questions that you've been submitting. The goal was for her to email those questions to me. So I'm going to see if I can find them. And if not, I'll have Allison communicate them to me otherwise. So let's see. Webinar questions. I asked her to organize them in some way, so let's see how well she did. So is this option available for someone who has multiple small tumors, all under 10 millimeters in the breast? Can it be done in one lesion and then wait a while to do another? So what she's describing is a situation of is multifocal, multi-breast cancer, where there are multiple deposits in the breast, all cancer, in one region of the breast. That's how this reads to me. It is a situation that we treat with cryoablation, but it is a situation that's most appropriately treated when the entire region is ablated. So not just one lesion, but the entire area with margins. If you only treat one area, the others will likely grow. Some people think that you can treat one and treating the other, and the others won't respond because of this abscopal effect that they hope will happen. I made the point. It's unproven in human breast cancer as a result of cryoablation. There's some role with radiation, some linked to radiation, but it's unproven for breast. So for that problem, I would recommend treatment of the entire area, not just one area. Those other areas will likely grow if you only focus the treatment on one. The second question is, I have read that the site could swell to the size of an egg and stay that way for a year or two. What happens to the tumor once it has been frozen? How does the body get rid of it? Well, the tumor is killed with cryoablation. It's either killed immediately or the killing process continues over a few days with the tumor's ultimate death. I'm going to advance to some slides that I will show you that kind of make the point. Initially, there is what's called a ghost tumor, which is basically a mass that remains at the site of the tumor. This is an example of a kind of a ghost tumor. So this is a cryoablation zone. This is the ghost tumor is basically scar of the tumor. And so there is this area that you can feel that usually spans the size of an egg that gradually dissipates over the course of years, not just 2 years, it could be longer. I think for fatty breasts, it takes longer. For dense breasts, it takes less time, but in all cases, it takes multiple years. In this image, you have 2 cases of cryoablation, mammograms performed 1 year after cryoablation. You see this sort of egg size or area. Eventually, that area gets smaller. And this is a patient 3 years later. You can see the clips that were left at the biopsy site, at the cryoablation site, but there's no visible mass left. And it's the very same patient. This is the patient's pre-cryoablation, her MRI. This is post-cryoablation MRI showing no finding there. This is 3 years later. So it takes time for these things to disappear. But initially, there is this egg size area of treatment. If you've had one ablation, if you've had multiple ablations, it's more than one egg size. And that disappears over years. Basically, the body digests it. Just like it digests any area of injury, it digests the dead tissue and replaces it with collagen or scar. There's no volume loss as that process is taking place. The volume of the breast is preserved. So the next question is, can cryoablation be done on a lesion close to the chest wall or in a small breast? Yes, it can. We routinely treat patients with small breasts, with breast cancer and small breasts, are those that are close to the chest wall. And the main thing is that, we use hydrodissection, which is injection of a solution like saline between the chest wall and the tumor, or between the skin and the tumor, to create space for the ice ball to grow. Even in the small breasts, you can inject a lot of saline to expand the space so that you can grow an ice ball. So whether the patient is a small breast or a tumor in the thin part of the breast, or she has breast implants, which kind of flattens the whole breast, makes the whole breast thin. In all of those scenarios, we're able to safely and effectively treat tumors with cryoablation. It just requires experience and technique. How can you do MRI without contrast before cryo? Well, as I made the point in the presentation, effective MRI for breast cryo requires contrast, because it's very hard to see breast abnormalities without the use of contrast. So breast MRI requires contrast. Now, there is a type of breast MRI called diffusion weighted imaging, which does not use contrast. It is not widely available in the US. If you can find it, that's great. There is a type of breast diffusion weighted imaging, which is whole body MRI, not just dedicated breast MRI. Whole body MRI doesn't have sufficient resolution to look at the breast. Even though it doesn't use contrast and it includes the breast, it doesn't look at the breast with enough resolution to guide cancer treatment. So the most appropriate MRI for breast cancer evaluation is contrast MRI with gadolinium. And unfortunately, that's the reality of it. Although there are technologies that are emerging in the future that will potentially eliminate the need for gadolinium. They're not widely available now. The next question is the 2% local recurrence rate for the ICE3 trial. Are there more details where this came from radiotherapy group or the other group? I actually don't have that detail, but as you remember, only 15% of patients in the ICE3 trial had radiotherapy. So it's not likely radiotherapy was a significant contributor to that risk of recurrence. And the majority of patients, 75%, had endocrine therapy. So it's likely, that the effectiveness of the treatment was made possible by the combination of cryoablation and endocrine therapy, and that there were some tumors that recurred either because they were not effectively controlled by that, or more likely, there was just tumors that were in the perimeter of the cryoablation site that were not ablated because imaging did not reveal their presence. That's the usual reason why we see recurrences after cryoablation. It's not a cryoablation of the thing that we targeted. It's not recurrence of the thing that we targeted. It's recurrence of the surrounding tissue that at the time of cryoablation looked normal, but in retrospect proves not to be normal. The next question, can you treat Paget's disease with cryoablation? The answer is yes. First of all, Paget's disease has two issues to manage. One is the issue regarding the skin and our areola. The second is the issue of the cancer in the breast. Paget's, which is carcinoma involving this nipple and our areola, generally arises from a tumor growing within the breast. So you have to treat that as well. Our approach is usually to ablate the tumor within the breast if it's manageable with ablation, and then to excise the nipple or to excise the areola, because we can't ablate the skin and nipple without killing it. There's a little bit of evidence showing that if you treat the tumor below and irradiate the breast and the skin, that the radiation may actually adequately control or kill the Paget's. That is an option for someone who refuses to have the nipple areola removed and who's willing to have radiation. But basically, you have to manage the skin and you have to manage the tumor within the breast. But it's definitely manageable with cryoablation. Someone asked what does PCR mean? I think I mentioned that. PCR means, or at least it's on the slide, pathological complete response. So that means when you pre-treat with drugs and then you perform surgery or a biopsy of the site that was pre-treated. If there's no residual tumor left at that site, we call that a pathological complete response, or a PCR. That's kind of the optimal result that we get, but we're seeing that increasingly today with better drugs like anti-HER2 therapy and triple-negative breast cancer therapy. We're frequently seeing PCRs achieved in patients where the disease is completely eliminated from breast, completely eliminated from lymph nodes. Those patients have the best survival amongst patients with breast cancer. And so that's why we are trying to develop better drugs and pre-treat patients so that we can identify if they can achieve a PCR. And if they don't achieve a PCR, it means that the tumor responded, but there were still some surviving cells. Those patients with surviving cells may need to have additional therapy. So pre-treating triple-negative and HER2-positive patients helps us identify those with a PCR, as well as those who still have residual disease who might need something more. I was asked to talk about the news that Medicare will cover cryoablation for breast cancer. So there is a recent decision that Medicare will provide. This information is relatively new to me, but I'll share with you what I know, or as I understand it, that Medicare will cover the facility fee when cryoablation is administered in a hospital setting. So if your cryoablation is being performed in a hospital or in a radiology center that's a part of the hospital, then Medicare will cover the facility fee, the cost that the hospital pays for the cryoprobe and for supplies. That principle does not apply to cryoablation being provided in the private office setting of the radiologist or private office setting of the surgeon. They're not covered by that decision. It's a hospital payment that Medicare is paying. The decision about coverage of the facility fee, even in the hospital, does not at all address the professional fee, the fee for the provider providing the service. The last point that I make is the decision about Medicare coverage is contingent upon the FDA providing an approval for cryoablation for a specific subset of patients. The application that has been presented to the FDA is for approval for patients with small tumors, 15 millimeters or smaller, low to intermediate grade. We call them luminal A tumors, node negative, in patients age 60 and older. So the patients that were included in the ICECure trial, those patients that met the criteria of the ICECure trial for the most part, those are the ones for whom the FDA approval is expected, and those are the ones for whom the Medicare coverage is expected if they receive that treatment in a hospital setting. It does not apply for patients with different kinds of tumors, with larger tumors, or for those that are treated outside the hospital setting. And in none of the scenarios that it applied to the professional fee that goes to the surgeon or the radiologist who actually provides that treatment. That has to be paid differently. That's what I understand. And as the data become clear or as they're updated, I'll make sure that you learn about it in the future. So I think that was the last question that was submitted to me. There were others that might have come forward, but that's the last one I have in email. It's also time for us to wrap up. So I thank you for joining me today. Sorry it's a little rushed, but I finished putting together the slide presentation in the wee hours of the morning, and I wasn't actually sure how long it would take to give it. It's a little bit more than I can give in an hour and a half, but it's all in the draft. So we're going to make the slide deck available through one of the social media channels so that you actually do have the video component to go with the slides. But I encourage you to have a look at the draft presentation that's on my website, to send your comments or questions if there's something that's not clear, or if there's something I left off, or if you had a different experience that you don't think was accounted for in the draft. I welcome the opportunity to learn about that so that I can address it in the appropriate way in the guideline. Again, I intend for you to be able to utilize the guideline to learn about it, but also to share with your providers who may not be so knowledgeable about it or might be skeptical about cryoablation. It'll give them a lot of useful information to think about it. And of course, if you're looking for someone to perform cryoablation on your tumor, I think one of the points is that it's more than just sticking a needle in the tumor. There's a lot more complexity to managing not only the tumor, but you as a patient. And these are the kinds of things that need to be considered in decision making about that. So on that point, I thank you all for spending a part of your day with me, and see you next time. All the best.